Hello, I'm Larry Wurn. I'm research chair at Clear Passage Physical Therapy. Been asked about how can manual physical therapy possibly address adhesions and bowel obstructions, adhesions in the abdomen and pelvis. There are some rather compelling studies. We're going to take a look at that and see really how effective it is, how safe it is, if there are concerns in that area. Specifically, we'll look at two studies. One of them is a case report. It was authored by surgeons from Harvard, Stanford, and Washington University, gastroenterologic surgeons, and it has some interesting information. Another is actually a phase 2 control study in which we compared people who received the therapy with the standard of care, which is just basically no therapy. Again, the same authors there. Question is, really, honestly, can a manual physical therapy decrease or stop recurring bowel obstructions? And the second question, really, in the control study, published in the World Journal of Gastroenterology, is can it actually improve the quality of life for these patients? And we'll talk quite a bit about that. More specifically, we're going to look at how do we go from this, a 3-inch string stricture in the terminal ileum, looked like a coffee straw, to this, a normal bowel without surgery. Or from this, an hourglass-shaped stricture higher up in the jejunum, to this, a normal bowel using only our hands. Is this really even possible? Well, we know it's possible. We have the films here, and we'll see that, and we'll look at why we think this happens. The problem really is adhesions. Adhesions are the primary cause of small bowel obstruction, specifically post-surgical adhesions are. This is a huge problem in medicine. A recent study in JAMA, the Journal of the American Medical Association, examined emergency room procedures, and the most common emergency room procedures, adhesion surgery and small bowel obstruction surgery were among the top 10. As a matter of fact, number 2, the second most common emergency surgery, was for small bowel obstruction, and the number 5 was adhesiolysis, the destruction of adhesions. The highest cost and highest complication rate was with small bowel obstruction, almost 50%. And we'll look at why a bit. The U.S. Department of Health and Human Services in 2010 said the average cost of an adhesion surgery is a little over $65,000. Given the number in that year, that equated to $25 billion a year. Even more poignant, 1 out of 8 patients were readmitted to the hospital within 30 days after that adhesion surgery. Bowel obstruction surgery is even more expensive, about twice as much, $114,000 a year according to HHS. There are fewer of those done, but still they amount to $11.5 billion per year according to AHRQ. More poignant still, 1 in 6 of those patients is readmitted to the hospital within 30 days after that surgery. As the politician says, $1 billion here, $1 billion there, pretty soon you're talking about real money. So $36.5 billion a year just in 2010. This does not include the thousands of ostomies, colorectal resections, and related surgeries. Even more compelling, perhaps, are the human costs of this. If a person suffers a bowel obstruction, Department of Health and Human Services says they spend a little over 2 weeks on average in the hospital. While they're there, they have IV hydration, IV narcotics to stop the pain, some nutrition because they can't eat, no food will pass through, they're going to die if they don't get nutrition. An NG tube, nasogastric tube, is passed through their nose, down their esophagus, and into their stomach to pump out their stomach contents, and they lie there in bed with these tubes in them and this pump in them for an average of 14.2 days, wondering, am I going to die? What's going to happen to me? Am I going to have surgery? And now my doctor tells me this could happen again. Problem is that no matter how brilliant, skilled, and compassionate the surgeon, surgery is not a guaranteed fix. As a matter of fact, surgery, just from the healing process of the body, causes more adhesions and tends to cause, therefore, more obstructions. As a matter of fact, it's cited numerous times as the primary cause of small bowel obstruction. The patient is left feeling, I'm helpless. There's nothing my doctor can do. There's nothing I can do to stop this. What in the world am I going to do? We know that adhesions and bowel obstructions have been a huge problem in medicine for decades, probably for centuries. It's a recurring problem. Once you have a bowel obstruction, you're liable to have another one. And a huge study published in Digestive Surgery examined over 5 decades of abdominal and pelvic surgeries in the United States. In that study, 100 to 55% of the patients developed pelvic adhesions and 90% developed adhesions in their abdomen after the surgery. Lancet, the highly respected British medical journal, did a study of adhesion-related hospital readmissions after abdominal and pelvic surgery. Huge study, 29,000, almost 30,000 patients in that study. In the Lancet study, we learned that 35% of those 30,000 patients were readmitted to the hospital more than twice after their abdominal or pelvic surgery during the time of that study, and that reoccurrences and readmissions continued to climb toward the end of the study. Risk factors for repeat bowel obstruction are noted at 40 to up to 2/3 of all elective procedures in abdominal surgery are actually reoperations, so physician going back in there again to treat adhesions. Reoperations also increase the risk for complications due to the need to destroy adhesions. As we mentioned earlier, post-surgical adhesions are frequently cited as the primary cause of bowel obstructions, and repeat surgery, as we are starting to learn, increases the risk of adhesions, obstructions, and more surgeries, and most general surgeons know this. The current standard of care is gastric decompression, this NG tube passed into your stomach to pump out your stomach contents constantly, because nothing will go through there. They'll use full-strength gastrografin sometimes, and then IV hydration for the first at least 24 to 72 hours. Of course, they have to keep that in if the patient remains in the hospital. Nothing really in the current standard of care addresses the internal adhesions. Nothing addresses the risk of subsequent obstructions. This is a huge problem in medicine. It begs the question, how do we stop this vicious cycle? Is there a way to stop this cycle that is confounding patients and physicians? Would it be important if we could stop or even decrease post-surgical adhesions and bowel obstructions using a manual physical therapy, using just our hands? With clear passage approach is one that we're going to examine and was examined in a phase 2 study published in 2018 in the World Journal of Gastroenterology. 2 aims of the study were to determine whether this therapy could help decrease or stop recurring bowel obstructions, and could it improve the quality of life for patients. Now, I hear you thinking to yourself, what in the world are you talking about? Physical therapy? I mean, I know physical therapy. Physical therapy is using modalities. Well, no, it's not modalities. It's not ultrasound. It's absolutely not massage. This is a deep soft tissue work that is very site specific. We know that manual physical therapy, called physiotherapy in most of the world, is effective at treating adhesive capsulitis, radiculopathy, other conditions in the body. We wonder now, with this approach, we call it the clear passage approach, is it possible that that could decrease adhesions in the small bowel? This therapy, we originally designed this to address adhesive cross-linking. It was very personal to us in the beginning. My wife, a summa cum laude physical therapist, developed severe adhesions following cervical cancer. The cancer treatment involved putting a tube with irradiated material at the full depth of her uterus. They kept her in a lead-lined room for 72 hours at a time. Nurses said, you know, it's dangerous for us to be in here, but don't worry, we'll keep you drugged. Just try to not move so that radiation will affect the tumor. And they did that twice. So she was in there for 144 hours altogether. At the end, the cancer was cured, and the doctor said, you're doing great. No more cancer, no more tumor. But a year later, she said, you know, I can't walk, move, or breathe without pain. What am I going to do about that? Oh yeah, that's adhesions. Well, you know, it's your vagina. We certainly don't want to do surgery there. That'll just cause you more pain. You're just going to have to learn to live with it. Nothing can be done about that. So we started studying adhesions. We learned that adhesions form in the body over the course of time. Once they form, they generally tend to stay there and sometimes grow. When they do, they can grow in the abdomen and pelvis, as we've already seen in some of the data earlier in this presentation. They can cause obstructions as they squeeze the bowels, like a garden hose, or kink it, or can even grow on the inside of the bowel, although I understand that that's more rare. Certainly in the bowel wall, we believe that they are a primary reason for strictures. This clear passage therapy, what we did when we started trying to get my dear wife out of pain, we realized that these collagen fibers, shown here attaching some endometrial tissue to the underlying structure, probably a uterus in this case, in this drawing, these strands are very, very strong. Type 2 collagen is stronger than steel by weight. You wonder, how in the world can we break those? Well, the thing is, we don't think we're breaking them. What we think we're doing is detaching them from the underlying structure at one side or the other of that cross-link, because we realize that attachment is really the vulnerable place for adhesions. Adhesions are formed by thousands of these little strands that lay down on top of each other and attach to each other. The glue-like portion is a molecular chemical bond, and that bond and our focus is to detach those bonds. It becomes like pulling apart that adhesion, like pulling out the run in a sweater, if you will. As those detach, that we start to gain mobility. As we start to gain mobility, tissues become detached from each other, and adhesions seem to dissipate. We'll look at some studies on this, because we do have some studies documenting the safety and effectiveness. When we started treating patients for adhesions after I got my wife out of pain, we started treating patients for adhesions. We realized that we were surprised to find that we were opening blocked fallopian tubes. And we thought, well, that's pretty bizarre. We notified the gynecologists in town. Most of them thought we were selling snake oil. The chief of staff of the hospital called me and he said, Mr. Wurn, I'm a surgeon. I've been a gynecologist surgeon for 30 years. I'm very good. He was chief of staff of the hospital. He said, what is this about opening blocked fallopian tubes? I showed him a few charts, and he looked at one, then looked at the other, and he said, sir, you're doing things with your hands I'm not sure I could do surgically. And I said, is that okay? And he said, well, yeah. He said, it's fascinating. Do you do any research on this? No. Would you like to? I said, yeah, sure. So he said, let's start with the scientific method and start conducting research. We started with examining blocked fallopian tubes, where we could see hysterosalpingograms, x-rays of dye that was stopped, shown here in white, stopped going through the uterus. That's the inside of the uterus, that triangle on the left. Would not go through all the way to the tube, the end of the tube, and then after treatment, that dye often went all the way through the tube and made this little cloud-like structures as you see on the right. We thought, well, that's pretty interesting. This was all blinded testing. We gave it to radiologists that didn't know this at all. We started conducting some tests, And we published a little pilot study in 2008. We only had 28 women in it, all of whom came to us with total bilateral occlusion. Some had only one tube and it was blocked. Some had both tubes. In all cases, all of their tubes were blocked. Of those 28, we had a 61% success rate opening blocked fallopian tubes. I thought that was pretty cool for a pilot study, so we decided to go on. Then 7 years later, 2015, we did a larger study of 10 years of women that we had treated, a lot of whom, 235 of whom, came to us with total bilateral occlusion. We were able to open fallopian tubes once again in 61% of the patients. This compared pretty well with surgeries that we could find. The clear passage approach shown here in blue, it's just a couple of the comparable surgeries that we could find for actually opening tubes. But when we looked at functionally, we found that we were seeing a lot more pregnancies than the surgeries that we were finding. So we're finding that once we were opening the tubes, they would stay open, where with surgery, so often they would close again within 6 months, and most gynecologists acknowledge that and will tell their patients that. We started wondering, well, wait a minute, if we can clear obstructions in these tiny little tubes, can we help people with recurring bowel obstructions? It'd be huge. Patients are facing awful choices, and so are their physicians. So we did a similar study, just a case study here with a woman, a Crohn's patient that had two different strictures in her body. One was that string stricture that we saw earlier. We see the radiologist's note to the right. This is the before therapy picture, and the after therapy, he said this is a normal bowel, it's a normal caliber and appearance for that bowel. Here are the two of them next to each other, before and after therapy alone, just using our hands. It's starting to get exciting for us. This same woman also had an hourglass-shaped stricture much higher up in her bowel. Again, the radiologist notes shown on the right, before and after resolution of the jejunal stricture. So that bowel worked fine. It worked normally after therapy. We realized, hey, this is going to be important to physicians, patients, insurers, and really to public health. We need to create a controlled study. So we did. We published a phase 2 control study in the World Journal of Gastroenterology recently. We had two groups. The control group had no therapy, which is the current standard of care, and the treatment group had therapy. We examined them before and after a 90-day period to see if they had recurring obstructions, recurring surgeries. Did they have any change in their quality of life and the costs? When we looked at the two groups before the study, we realized that the therapy group kind of had the deck stacked against them. They were 18 years older than the control group, with a very significant probability value shown there. Prior surgeries, the therapy group had twice as many prior surgeries as the controls. So again, should be much more adhered. The years impacted by small bowel obstruction, again, the therapy group had nearly twice the number of years impacted by bowel obstruction, with a probability of, 1 out of 10,000? That could have been by chance. So the p-value was highly significant. The prior partial small bowel obstructions, again, the therapy group had a little bit over double the number of prior partial obstructions. The prior total obstructions, the control group actually was slightly higher, but it did not reach the significance of probability. So the biostatistician, those of you that understand biostatistics, understand that he said basically that does not count. When we looked at the results at a 90-day follow-up, we looked at these results in each of our patients. The partial bowel obstructions, after 90 days, the control group had 2.5 times as many partial obstructions as the therapy group. Highly statistically significant. Total bowel obstructions, the therapy group had less than 1% had total bowel obstructions during that 90 days, and you can see the control group had about 15 times as many. Again, high probability value, very credible results. Repeat surgeries were the controls had about 3 times as many requirements for repeat surgeries during that 90-day period. Again, statistically significant. Every good study looks at adverse events. What happens? What is the danger? The main thing that we saw was aching or tenderness. It's almost like the feeling that you have when you work out and you haven't worked out for a long time, that lactic acid comes out. So people would get sore sometimes some back or hip pain, but they're out walking around. They're not in the hospital. They don't have tubes in them. This is an outpatient procedure. They're going out for lunch and dinner every afternoon and evening while we're treating them. We wanted to look at quality of life. The obvious ones are listed here. With the therapy, there's no surgery or NG tubes or medications. We also instruct each of our patients in what's going on and how they can treat themselves, how they can prevent obstructions in themselves if they feel something coming on. In order to help quantify more specifically changes in quality of life, we actually created and had validated and published a quality of life survey for patients with bowel problems. And anyone who works with bowel patients can use this now. It's on PubMed, it's on the internet. When we looked at the before and after results, the biostatistician found significant improvements in 5 of the 6 measures of quality of life shown here. A little bit more specifically in those, this is some of the measures that we looked at: what they could eat, did they have pain in their upper or lower GI tract, bowel movements, what was their diet like, were they on a liquid diet, could they eat soft food, solid, anything. We measured their gastrointestinal symptoms: nausea, vomiting, gas, that kind of, the spasms, the kind of things that we hear from these patients. We also measured quality of life. Did you miss work? Did you miss social activities? How much did you fear that you were going to have another obstruction? And those numbers were pretty much off the chart as far as the ones that we treated had much less fear and much more confidence that they could handle anything that came along, because now they understood what was going on and they learned to treat themselves some. Significant improvements were also shown in the control group, just at a p of 0.05 in 2 areas, the general pain and gastrointestinal symptoms. Those of you who understand statistics will understand this next phrase. I don't, but the confidence index was close to 0, so the actual improvement could be very small, the biostat said. I don't know. It's not my bailiwick. One of the things that we measured for quality of life, being physical therapy, is their range of motion, their trunk range of motion. When you are adhered up front, it pulls you forward. You have a hard time bending back. You have a hard time side bending to the left or right. Rotation is more difficult because you are gripped inside with these estimated at 2,000 pounds a square inch bonds that are gripping structures inside and decreasing your mobility. We saw range of motion improvements in all 6 ranges of trunk mobility. Here's a little bit closer look at all of that, the before and afters for flexion, extension, side bending, and rotation. This closely paralleled a poster presentation we presented at Digestive Disease Week in Washington, D.C. in 2015, the abstract published in Gastroenterology, the full study published elsewhere. You can PubMed it. If you Department of Health and Human Services, the average cost of a bowel obstruction surgery, including the hospitalization, was over $100,000. Our therapy was coming in, varies, but somewhere around $8,000. So if we could save one obstruction surgery, that we're saving an insurer over $100,000 on that one surgery. Treatment comparison we've already talked about. The no hospitalization, no narcotics, no IVs, no hospitalization at all. We realize that a physical therapist can treat under our protocols about 75 patients a year. So 2 of them would treat 150 surgical candidates every year. The expected surgery is 35%. We know from the Lancet article we're going to have 2.1 more surgeries. That's 110 surgeries that we can expect out of that group of 150. The cost savings from hospitalization for the total bowel obstructions go from 15% to 1%. So 14% of those, which is 21 patients, avoid the hospitalization. So we have some savings from hospitalization in that group that only 2 physical therapists are treating. We have savings from lack of surgeries of over $6 million. Altogether, once we deduct even a very generous salary for physical therapists, a couple $100,000 for them in their room, those 2 PTs are saving about $6.5 million a year using these numbers. We looked at this public health aspect for a larger group because we know how prevalent this problem is in America. If you had one hospital, we're saving $6.5 million. If an insurer or other group owns 12 hospitals, we're going to, using these numbers, save them almost $80 million a year. Some of the larger insurers that own 51 hospitals, for example, if we train only 2 physical therapists in each of those hospitals, it's going to save them, using these figures, a projected over $300 million every year. Takeaway, we've looked at our history of adhesions. We've seen before and after films of strictures eliminated, obstructions eliminated. We looked at the phase 2 study, the complexity of the control group versus the treatment group, and how we would have expected many more problems with the treatment group. Partial bowel obstruction outcomes were 2.5 times what the controls were. The small bowel obstruction, we had 15 times the success as the controls. We looked at the improved quality of life, the range of motion, no adverse events. We looked at the costs of outpatient treatment versus hospitalization, and also a cost comparison for the payer for all of those. So that's where we are today, okay? I thank you very much. Again, I'm Larry Wurn, Clear Passage Physical Therapy. If you'd like more information, you may go on our website or search these studies on PubMed. Thank you.